Good evening. My name is Patty Dash. I'm the Executive Director for the National Kidney Foundation serving Maryland and Delaware. It gives me great pleasure to see so many of you joining us here this evening for this very important talk. It also gives me great pleasure to introduce our Medical Advisory Board Chair. But before I do that, I am going to ask that everyone please stay on mute until you want to ask a question. That way we don't hear any background noises. But otherwise, sit back, relax, take this in. This is being recorded, and we will send it to you after the presentation. So with that said, Dr. Brown is our Medical Advisory Board Chair for the Maryland and Delaware market. We are so honored to have him join us here this evening to introduce our speaker. Dr. Brown?
Thanks, Patty. So I've known Dr. Klassen, I guess, since, believe it or not, 2008, when I started as a fellow at University of Maryland, and he was one of the senior transplant attendings at that time. Dr. Klassen did his medical degree at Ohio State, and all of his training at Hopkins was at Maryland for quite some time. And then left University of Maryland in 2014 to join UNOS, where he's currently serving as their chief medical officer. And I thought would be the perfect person to speak with us regarding some of the new challenges with kidney transplant allocation, which he so kindly agreed to do, and I will turn the floor over to him. So, Dr. Klassen.
Okay, thank you, Eric. I appreciate the opportunity to talk to you. It's a good subject. It can get a little bit in the weeds at times, but I hope I can make it somewhat interesting and kind of go over, where we've been with respect to organ allocation and kind of some of the upcoming changes as well. So am I controlling the screen now? Looks like I am. Okay, well, thank you again. Thank you very much. I have the typical conflict of interest slide here, no off-label content. I think it's important to point out I'm not representing officially in any official capacity HHS or HRSA, who provides the contract from HHS to UNOS. I am on the scientific advisory board of a small company that hopes to 3D print organs, but I'll move on. So first slide here is, sort of what is UNOS? I'm going to start very basically, and I think everybody probably knows this, but nonetheless, UNOS is the United Network for Organ Sharing. It's a nonprofit corporation based in Richmond, Virginia. It holds the contract from HRSA to operate the Organ Procurement and Transplant Network, which is something we're going to talk about in depth. And UNOS has held the contract really since the inception of the OPTN in the late 1980s, actually. Next slide. So what does the OPTN do? The OPTN does organ allocation, obviously, for all solid organs, not just kidneys. We're going to focus on kidneys tonight. But we also construct, with input from the transplant community, obviously, the matching algorithms that are used to distribute organs. We collect all the data, both pre and post-transplant. And we also provide that data back to the transplant community for research purposes. We do our own in-house research. We have a very robust research department that has over 40 people in it. And they have excellent training and are quite talented, actually. And we have quality oversight of transplant programs. We look at policy compliance, and we do a lot with patient safety, including issues like disease transmission. The legal framework for the system really comes, and I think it's important to understand this because the legal framework kind of sets up sort of the structure of the system and how it operates. And it really was established by an act of Congress, and some of the peculiarities of how the system appears to be today really come from the legal requirements of the way it has to be operated. And a lot of the operational things came as a result of what's called the final rule, which was issued in 1999 by HRSA or HHS. So one of the things that is stated very explicitly in the final rule, is that the allocation system has performance goals, and it's seeking to achieve the best use of donated organs. It shall not, and again, this is going to be more important as we go through the allocation system, shall not be based on the candidate's place of residence or place of listing. Allocation policies shall be designed to achieve the best equitable allocation among patients. And also it's designed to distribute organs over as broad a geographic area as feasible in order of decreasing medical urgency. And these are requirements, they're not choices that we get to make, although you can see that some of these goals can conflict with each other on occasion. This next slide. I want to kind of ground us in some of the data, like where we are currently with respect to the transplant system. I think it's important to know that over the years, the number of donors has increased fairly substantially and fairly dramatically, especially in the last 7 or 8 years. You can see that on the left there. Those are the deceased donors, of which there are now over 14,000 a year. The number of transplants, again, this is of all types, has increased steadily as well. And last year there were over 40,000 transplants of all kinds. There was a brief downturn, you can see on the left graph there in 2020. That's the result of the pandemic that we're also painfully aware of. That did decrease transplant numbers transiently, predominantly through living kidney donations that were down a lot. Next slide, please. Let's focus here on kind of the most current kidney transplant data from last year. And in fact, there were over 24,000 kidney transplants. They were divided, about a third or 25%, I guess, were living donor transplants. There were 18,000 plus deceased donor transplants. There were, as I said, 14,000 deceased donors. And currently, the most recent number, there are 89,000 plus individuals on the kidney transplant waiting list. And there are about 40,000 who are added every year. So the challenge is to allocate to these patients in an equitable and effective manner. Next slide, there we go. So the kidney system over the years has really evolved quite significantly. And if you go all the way back to the late 1980s, up to the present time. And I think it's fair to say that the changes that we've seen have been driven largely by concerns over equity. And to some degree, efficiency and outcomes that are based on changes in medical management that have evolved over time. So really, we have sort of the initial system. And I'm going to try to kind of go through how we got to where we are now, which is listed here. I have the initial system, kind of the CAS system, which stands, kidney allocation system. It's a, very creative acronym there. And then the CAS 250 system, and then where we're going with continuous distribution that's coming up. But the initial system really did evolve over a number of years, driven largely by equity. Next slide, please. The system as it rolled out had a big component of geographic hierarchy. In terms of local organs procurement, followed by regional distribution efforts. And overlaid on this was waiting time, which was an important component. The degree of HLA match. HLA match has changed over the years. It prioritized, and still does, zero antigen mismatches or perfect matches. But the degree of HLA matching that the system utilizes gradually evolved to make it less HLA dependent. This was driven largely by equity concerns because of sort of mismatching between the donor pool that was available and the recipient pool. Immunologic sensitization, that is, the pre-existing antibodies in a patient against potential donors has always been important and still is. It went from originally sensitization of 80% or more got extra points. And then there has always been pediatric priority. But again, geographic hierarchy is important to understand. So next slide, please. This is a map of the OPTN, the DSA, which stands for Donor Service Area, or also it's equivalent to the OPOs in the country. There are currently 57 OPOs. It's important to look and understand how different they are. And I think, what I think is apparent is how varied, like the OPO in the northwest part of the country covers several states, whereas Ohio, for instance, has 4 OPOs within the state. And even here in Maryland and the DC area, we have 2 OPOs. And in some parts of the country, the OPOs aren't even contiguous, like in Texas. If you look at that, the OPO geography is very unusual there. And I think it's apparent that the OPOs were not designed for optimal allocation, but really they evolved through local relationships. But they've been maintained to this day. At one point, there were over 100 OPOs across the country, but they have gradually consolidated. Some cities at one point had more than one OPO. Next slide. These are the regions. There are 11 regions currently. Here in Maryland and DC, we're in Region 2, which includes Maryland, Delaware, Pennsylvania primarily, and West Virginia as well. And again, this is an important part, and historically has been an important part of how the allocation system is laid out. Let's go to the next slide, please. So I think the first big change really came in 2014 when the kidney, what's called the kidney allocation system, or has been called that, CAS, was implemented at the end of the year in December of 2014. And it was sort of, you could argue, a kind of a hodgepodge of attempts to achieve certain goals. One was to make, as listed here, make better use of available kidneys. And this was, again, trying to meet the goal outlined in NOTA of an efficient system and to make best use of organs. And what this did in the CAS system was try to match the organs that were expected to last the longest with patients who were expected to live the longest. This was sort of an efficiency or measure that was put in place. It was also designed to increase transplant opportunities for very difficult to match patients, primarily patients who are highly sensitized, who have high PRAs, if you will, the panel reactive antibodies. And that was put in the previous system. HLA was approached, HLA sensitization was approached just as a dichotomous thing. You were either over 80 or under 80, and you got 4 points if you're over, and if you're under, you got nothing. The CAS system in 2014 put in a continuous gradient, and patients who were very, very sensitized with PRA levels of 99 and up got a lot of points. And this again was an equity issue. And it also changed, very importantly, it changed when waiting time was calculated. Previously, waiting time for transplant was based on when you got on the list. And so many patients actually started dialysis and were not listed until years after they started dialysis. These are particularly patients with limited resources, perhaps. And so the CAS system changed that to peg waiting time at when a patient began dialysis, not when they actually got on the list. And this really had a big impact on who was transplanted. Otherwise, it was the intent was to leave other demographic groups essentially unchanged. So next slide. Again, this matching component of the kidneys most likely to survive the longest, the organs most likely to survive the longest, matching up with, and that's measured by what's called the KDPI, the Kidney Donor Profile Index, and it has 10 variables that are put into it. You can see them here, and it is calculated for every kidney, and this is matched up against, on the next slide, the estimated post-transplant survival of the patients who are waiting for kidneys, and that's based on a limited number of factors, but they are the important ones that in fact statistically drive survival: age, time on dialysis, current diabetes status, and prior transplantation. Next slide. So this is how the CAST system, and the CAST system has been largely retained in the current iteration of it, but it's important to understand that the sequences by which the organs are allocated are based on the KDPI. And so a KDPI in sequence A, these would be the 20% of organs that are expected to last the longest, are matched up again with the top 20% of patients listed there who have the highest EPTS. It gets a little bit confusing, I suppose. And then subsequent to that, you can see in descending fashion what the order of priority is. And then there are sequence B, C, and D for other KDPI categories. What's important to note here is that local procurement, locally procured organs, that is within the DSA or the local OPO, allocation goes to those candidates first who are local, followed by regional distribution if there are no local candidates who accept it. And that is something that we're going to talk a whole lot more about as we talk about the more recent iterations of this. And so again, you have this points system that has some differences based on KDPI and recipient characteristics that overlay on top of a geographic hierarchy with, local preference followed by regional preference, and then followed beyond that by national preference. And so that's kind of the core of the system that was put in place in 2014, and that still exists actually. Next slide. So I'm going to pivot a little bit here and talk about equity. The title of this talk was sort of the, issues around geography and equity, and these have sort of collided to a certain degree in recent years or recently. And so how do you measure equity? Obviously, there is, in the context of transplantation, there's no single correct way to assess equity. Is it, access to the wait list? Is it access to transplantation? Many have argued that the OPTN really has and issues of allocation are directed only at people who are already on the wait list. And so this is currently somewhat of a contentious issue. But if we're going to measure equity and try to make policy around equity, we need to have a way to assess that. And so UNOS, we kind of jumped into that controversy and took a stab at how to measure system-wide equity. And so I'm going to describe that now. Next slide, please. And this is a paper that we published back actually in 2018, not that long ago. And these are all authors from UNOS. I'd highlight Darren Stewart, the primary author, as sort of the driving force behind this. And so we devised a system that we thought could be used to monitor equity in access to deceased donor kidney transplantation. So the next slide, please. Let's see. Is there another slide beyond that? And one more. Keep on going. Yeah, I'm sorry. I didn't realize it was a sequence. And one more, I guess. One more click here. So what this methodology does is it really looks at the transplant rate. And this is sort of in the weeds, but basically it's the rate of transplantation as a function of various candidate features or characteristics, and you can see them listed there. And it looks at the variation in the transplant rate based on those individual characteristics. It has to be discounted, if you will, for intended disparities. There are, inequitable things that go back, if you don't mind. There are, pediatric candidates get medical, they get extra points, as do prior living donors should they require a transplant. And so there are inequities that are accounted for in this or have to be discounted for. And so what we look at is really sort of the variation in the rate of transplant, of transplantation among candidates. So the next slide. So we calculate what's called an access to transplantation score, and it's based on these patient characteristics. And here you can see some examples of this. So for example, on the horizontal axis are the number of days to deceased donor kidney transplant. And on the vertical axis is the probability of receiving a transplant, or in this case, being still waiting for a transplant. So the blue line, for instance, is a patient who is sensitized, has a CPRA of 80%, but is blood type A. And you can see that patient gets transplanted relatively quickly. The red line, or the gray line, for instance, is a CPRA of 0, somebody who has no sensitization, but is blood type B, which is relatively difficult to match. And that patient in the gray line has sort of a prolonged time to transplant. And then an extreme example is the red line, and that patient on the red line there is a CPRA of 99.99%, of which there are many such patients, who is blood type B. And what you can see there is that at 5,000 days post-listing, that patient really had a 10% chance of being transplanted. That's over 14 years. So these are real patients, and so the range of access to transplant varies. Next slide. And so you can kind of calculate I guess the density or the distribution of these access to transplant scores, or the statistical, the standard deviation. And so what you see here is sort of the variation. On the extreme left are patients who have very, very limited access to transplantation. On the extreme right are people who have very rapid access to transplantation. If we had perfect equity, this plot would narrow, and you'd basically have a vertical line at the 0 point, but clearly we don't have that. Next slide. You can use this to compare different points in time, actually. And so what you see here is in the blue, in the background there, is the variation in access to transplant before the CAS system went into effect in 2014, and the green is post-CAS. And what you can see is the narrower distribution of access to transplantation scores in the more recent version. That suggests to us that, in fact, that change improved system-wide equity. Next slide. You can use this methodology to look at allocation equity over time, and that's what this graph shows. This shows the standard deviation of the access to transplant scores over time, and what you can see is in December of 14, there was a precipitous drop, and there was about a 40% improvement at that point that has continued up until more recent times and continues today. And so that represents, presumably improved system-wide equity, if you will. And that was very gratifying to see that, based on the policy changes that were put into place. Next slide. Interestingly, you can also use this to look at the individual components of where the disparity in transplant comes from. What you can see here is that, interestingly, the biggest component, thank you, of where the variation in access comes from is from the DSA, the OPO, or the donor service area. And so, in point of fact, the biggest thing driving disparity, could you go back, please, is in fact the DSA. Where you live is the biggest source of disparity. Interestingly, other things that we look at, such as ethnicity, racial ethnicity, really has very little bearing. So once if you are on the list, there is very little disparity that we attribute to ethnicity, or to, for example, insurance type, gender, also kind of community risk scores, which is sort of a nationally derived index, or urban-rural issues. But the things that drive it are where you live in the DSA, your CPRA, your degree of sensitization, or your ABO blood type as well. Interestingly, education, prior kidney transplant have some role in that as well. Next slide. So the final rule, as you recall, says that organs need to be distributed over as broad a geographic area as possible and shall not be based on a candidate's place of residence. Quite clearly, where you live is a big deal in terms of your access to a transplant. Next slide. So this was apparent to us, obviously, but we weren't the only ones it was apparent to. And I think sort of the modern day that we're living in really kind of commenced from a transplant allocation standpoint. Perhaps you could argue commenced in November of 2017. There was a lung candidate who argued that the use of DSA as the first unit of allocation contravenes NOTA and the final rule, which says that's not supposed to be. And that person went to court to seek removal of DSA as a unit of allocation. And so that kicked off some important changes. Next slide. Again, if you look at the DSA map here, what you can see is that there are hard borders between DSAs. And you can argue that as this patient did, that was against the law as laid out in NOTA. For instance, if you look at the DSA map there, you might say, well, an organ in say Philadelphia, which is right up next to the OPO in New Jersey, that organ that organ is going to go preferentially to a patient in central Pennsylvania, as opposed to somebody in New Jersey who might be, a mile away across the Delaware River. And so that was a source of contention. You could argue that, Washington was able to cross the Delaware back in 1776, I suppose, or whenever, more easily than an organ does in the current 2000s. So that was a problem. Next slide. So the Secretary of HHS obviously got involved, and word came down to the OPTN that we needed to remove DSA and region from organ allocation. It wasn't it would be nice if you would do this, please. It was like, do it. There was no getting around it, and so that's what happened. Next slide. So what we moved to was to remove DSA and region from allocation, and this was done by replacing DSA and region. And this is the system now, this CAS 250 that we currently operate under. We removed DSA and region and replaced it with a single fixed distance circle of 250 nautical miles around the donor hospital. And so that became the first unit of distribution. But within that, there were proximity points, meaning the closer you were to the donor hospital, you were awarded extra points based on that. And there was a maximum of 2 points for inside this 250-mile circle, or up to 4 points outside the circle. Next slide. And this is, we tried to show this sort of diagrammatically here. So you have patients within the circle on the left of the graph, and they get, depending on how they fall within that 250 miles, they get up to 2 points, or as few as 0. If you're outside that circle, you can get an extra 4 points, but even those extra points do not allow you to kind of jump ahead of the people within the circle. So there still is this geographic hierarchy. It's now not a random hierarchy. It's designed specifically for allocation, and so it gets around some of the concerns about the randomness of the previous system, but it still does have hard borders, and so this is how the current system works. Next slide. So here's the same sort of sequence A, B, and C again, but what you see instead of sort of this priority of local, regional, and then national, you have this inside the circle and outside the circle, and that is the hierarchy. And it still maintains the current, the matching of low KDPI kidneys with patients who have the more favorable EPTS criteria. So this is the system that we currently operate under. Next slide. Some of the early results, again, this system, if you go back, the system actually, the Kidney 250 system that we have now only went into operation in March of 2021, actually. So it was, the implementation of that was delayed by various lawsuits that emerged in this whole thing. There were people who or transplant centers and institutions that preferred the status quo as opposed to the system that had been proposed, and so it wound up in court and was delayed for some time. Some of the early results, again, we have 6 months results. There's a delay in data collection, but it appears initially that at least on the first look at this, that waitlist mortality declined. That there was increased transplantation rates for pediatric candidates, and also for minority candidates as well, had a significantly increased rate of transplantation for African Americans and Hispanics. There was maybe a slight rise in the discard rate, and obviously there was broader distribution. Kidneys traveled further than they did before. So I've sort of plucked the 1 year analysis of the system is supposed to be released, I believe, next week. And so there'll be a whole nother round of analysis of the outcomes. And the 1 year monitoring report, these reports are available on the OPTN website. They're public documents, and they're packed with tons and tons of data. So if you're interested, you can look for that probably next week. I don't know how it's all going to turn out at the moment. You can kind of say, so I think these things are for the most part favorable, and maybe I've sort of cherry picked what I've wanted to see here. Not everybody has evidenced by lawsuits and whatnot has been happy with the system so far. Next slide. And this is an example of that. It does increase the level of complexity. This is sort of, again, kind of centered on Philadelphia, but within, and so that's a hospital, say a donor hospital in Philadelphia, or the OPO there has to deal with all of the donor hospitals now, potentially within this 250-mile circle. And so it adds a lot of complexity to the system. OPOs were used to working with their usual partners, which were much more limited. And so there has been pushback that the system becomes more cumbersome, it's more difficult, and organs travel further at increased costs and things like that. So clearly, there is a price, there is a cost, not just money, but a cost, when you change the system like this and add broader distribution with more complexity. And so again, we're still in the process of evaluating the outcomes from that. Next slide. With that in mind, realizing that the system currently, is not perfect, obviously. Back in 2018, the OPTN Board of Directors set up a work group to assess other options, in terms of how might organ allocation be done better and in the future. And some of those things, and so there was an effort that included a lot of input from within the OPTN as well as from outside the OPTN, and they looked at a lot of different ways to address the geographic issues of geographic disparity that was part of the system. They looked at something called optimized districts. They looked at variations of concentric circles. They looked at population-based circles. And they looked at something called continuous distribution, which is where we landed. And I'm going to talk about that more on the next slides, actually. Next slide. I like to give credit where credit is due. And this whole concept of continuous distribution was actually first put out there by Jim Burdick at Hopkins. I certainly knew Jim quite well. He's retired now. But he put out a paper back in 2001 that really laid this out quite nicely as a concept. It wasn't adopted, but I'm not sure that this paper was widely read at the time. Dr. Burdick went on to be the director of the transplant division at HRSA for the government, as well as being a surgeon at Hopkins in his earlier part of his career. Next slide. Also, driving this more recently has been the group from the SRTR, the Scientific Registry of Transplant Recipients. That's and this paper by John Snyder, who is the director of that. He really revived this notion of continuous distribution, a system without any geographic boundaries at all. Again, the problem is when you have a hard stop on geography, you always get these edge cases where somebody has access to a certain degree on one side of the line that may be different from somebody on the other side of that line. So getting rid of hard boundaries solves a lot of problems. So the next slide. So this is how John Snyder explained the model, his model to me, or his conception of that. And this is on the back of a napkin, actually, at a meetings some years ago. And what it is, it really sort of represents priority of transplant on the vertical axis versus a measure of time, which is sort of a mathematical function, which is that sloping line in the graph there, upon which stand candidates who have differing levels of medical urgency, and their degree of medical urgency is based on sort of the length of that line, or as if they're holding up a flag. And I think that's actually, to me, that made a lot of sense conceptually. And the person or the candidate at the highest level got the priority over somebody with a lower level. Next slide. So they actually, in this paper, they made a nicer presentation of that. And you can see that in the graph on the right. You have candidate A and candidate B that are imposed upon a mathematical function that represents geographic feasibility, if you will, of that transplant, sort of an equity, or not an equity, but an efficiency kind of measure. And so you end up in a continuous distribution framework of having a medical priority score, that's the height of the candidate's line there, with a proximity score, and that is combined into an allocation priority score. So candidates are then ranked in a simple system like this, strictly by their allocation priority score, a final score, if you will. Next slide. So this is being rolled out, and again, the board of directors in 2018 came to the agreement that all organ transplantation systems, allocation systems, would adopt a continuous distribution framework. And you can see there are different. These frameworks vary depending on what organ you are, but you can see examples here in the center of this slide. Features of kidney that might play into a kidney allocation system. There's aspects of medical urgency. You can put in post-transplant survival. There are candidate biology issues such as blood type, sensitization, the CPRA, maybe single versus dual kidney transplants. You have patient access issues, and then you can put in placement efficiency issues and things like that. And so you're not limited to, you can put in, depending on how complex you want the system to be, or what effect you want to highlight. You can use many different approaches to doing this. Next slide. So again, this slide shows sort of a kind of a basic continuous distribution function, or that results in a composite score. So you have, in this case, you have 4 separate domains. You have a medical urgency score. You have a placement efficiency score. You have an outcome score if you want one, to prioritize outcomes of any given transplant. And you have a patient access score as well that you could define in whatever way you chose. And you combine all these and you get the composite allocation score. And so when an organ becomes available, the distribution sequence or the offer sequence is based strictly on the patient's composite allocation score. So the patient with the highest score gets the first offer, or the first offer of a given organ. Next slide. Okay, and so you can weight, in this case, these are all weighted equally, 25% for each domain. Next slide. You don't have to do it that way though, actually. You can, in the lower level there, you can give different weightings to each of these domains. Here you can sort of see medical urgency, again, which is called out in NOTA as desirable. In fact, as a legally defined thing that we need to pay attention to. You can give that 40% weighting. Placement efficiency in this case drops down to 10%. The outcomes, the post-transplant outcomes, are weighted at 30%, access at 20%. And you can vary that based on how you set the system up. And all of these then, based on their weighting, combine into the patient's composite allocation score. This has the advantage of, these are value judgments. There is no defined requirement on how you do this, but it allows flexibility. You could change this to meet the needs of various organs, or any way you chose, however you chose to set it up. And so I think it becomes a system that is very flexible and very adaptable. Next slide. This then is sort of a hypothetical match run here that could be set up. And so we have patients A, B, C, D, and E here. They all have differing, medical priority. Patient D has a very high medical priority, but has a, in this case, it uses ischemic time. These are hypothetical cases. Candidate age group could be played in. So somebody who is a pediatric case, for instance, might get a whole lot of time based on their pediatric status. And so again, even though these are not all equivalent, it's the composite score that really counts. So in this case, and you can see waiting time in this case is relatively limited. But in this case, patient A has the most points. And so the offer sequence would be first patient A, then patient B, patient D, patient F, patient C, and then patient E. And so that's trying to illustrate how such a continuous distribution system with a composite score works. Next slide. So I think, kind of trying to sum this up, the benefits of continuous distribution is that you can argue that it is more equitable. There is no one factor that will determine a candidate's placement on the waiting list. It takes in many, many factors. I think it is flexible. The framework can be applied to all organ types, and it can be adapted to a specific organ type based on the different characteristics. I mean, clearly, we have never allocated, lungs the same way we allocate kidneys. It just doesn't work that way. And I think this system is relatively transparent. The value judgments that are inherently in these allocation systems and as they are constructed, I think in a continuous distribution system become apparent. How these different segments or different domains are weighted, is part of the system, and it's there for everybody to see. And I think, this framework potentially is more agile. We get a lot of criticism, at the OPTN for being sort of slow and ponderous in some respects, and that is to a degree by design, since policy changes have to go out for public comment and issues like that. But I think a continuous distribution framework does allow a system that can be responsive to changes, whether they are scientific or clinical changes that evolve. And so I think that is a positive aspect of this approach. Next slide. So this is, again, has started. This is playing out. This is sort of where we are currently. This slide was made back in January, but the lung system actually is up and running. So lung now has a continuous distribution allocation system. The lung system was already sort of geared to do this. It was easier to do because lungs were allocated by an allocation system that included, pre-transplant factors, post-transplant factors, and had well-defined geographic characteristics at that point. So it's up and running. The kidney system is being developed as we speak. The kidney committee is working hard on this. When it will actually come into play is a little bit difficult to predict. It's possible that again, all these policy proposals like this, which are significant, have to go out for public comment. So the community as a whole gets to see what is being proposed, and often things go out for public comment, come back, get revised, go out again. So I think the earliest a kidney system might go out for public comment would be in the summer. Public comment happens twice a year, actually, summer and winter. So that could happen as early as the summer, but maybe later. There can also be special public comment periods that are put into place. And then, it would be approved by the board at some point, such a system. And then there is programming time. The programming involving these complex systems is difficult. The software, you don't buy the software from Microsoft. All the programming has to be written by software engineers that work at UNOS. It has to be tested to make sure it works as intended, and that takes some time. So the earliest I can imagine a continuous distribution for the kidneys might be 2024. Although it's interesting, you may be aware, there was a National Academy of Sciences report on equity, on how to make the most equitable transplant system that just came out recently. And the National Academy of Sciences report really highlighted continuous distribution as something that needed to be prioritized as soon as is feasibly possible. So we're working to do that. Again, I think continuous distribution for kidneys, it is coming. You will get a chance to comment on it, but it still is probably a ways off in time. Next slide. We do have some ongoing other work that I just wanted to briefly mention. In addition to these sort of structural changes to allocation, we are always working to, improve access within the existing system. We have sort of offer filters project that is going on right now. That's designed to make the system that we currently have to move faster, so that centers can filter off before they even happen offers that they don't want to receive. So if say a transplant center doesn't want to receive offers for a certain group of patients, offers of over donor age something, they can filter it off. And so it's actually a well-designed system to speed the system. We also have a predictive analytics project that's in the works right now. I think the next slide shows an illustration of that. And that's here. And so it's an interesting thing. It's sort of a decision support tool. And what this does is, this is up and running now in a pilot form. So when an organ offer goes out, the receiving center also sees at the same time some decision support tools. And what they see is the time to next offer, which can be determined by KDPI. When will this patient likely, statistically, be expected to receive another offer? But then that is also displayed on top of the patient's probability of survival going forward. And so it offers the clinicians the ability to contrast and assess, how long to another offer versus how long this patient's projected survival is. And so based on that, centers can express their interest or lack of interest in a given offer. Again, the idea is that this will provide support and allow people to make better decisions that we hope may improve organ utilization. Okay, next slide, and I think that's the end. And so at this point, if anyone has questions, will do my best to try to answer them. thank you very much for your attention. I appreciate everybody's interest in the topic. It gets a little dense occasionally.
Oh, thank you. I think the easiest way to do questions is just in the chat box, and then I can kind of field those and read them out, and everyone can hear them that way, and then you can have the ability to respond. One of the questions that I came up with just along the way was, it kind of struck me, this composite allocation score. Do you foresee this being something used by transplant centers to sort of determine whether someone's going to be a candidate in the first place? I mean, can you see a center kind of saying, listen, I just don't think your score is going to be high enough based on when your first predicted offer would be, and based on what your mortality is expected to be, we're not even going to go down the process of listing you.
Yeah, I think that's sort of decision support tool. I think that it would be more likely to utilize sort of the predictive analytics project that we have now. I think we're using that tool right now to sort of address, in a real-time fashion, organ acceptance or refusal of offers. But a tool like that could also easily be used at discussions with patients when they come to be evaluated. You can sort of see, expected survival, time to offer, things like that. And so, yeah, I think we're certainly anticipating that could be the case. I think there's a lot of data analytics that could be used up front to educate patients. And so I think that would be a great, that would be a useful step forward for sure.
All right, so one question that just came in was, with the new allocation system, does it still benefit patients to double list within that same 250-mile radius? So for example, at university and at Hopkins.
Yeah, that's an interesting question. It's double listing still is permitted. That has been a sort of a contentious issue for years, to be honest. And I think, is there a value in doing that? Can you get my slides back up? I do have one extra slide, a couple extra slides. Patty, can you do that? And if you go to the very end, yeah, next slide. So we kind of delved into that a little bit deeper with our equity access to transplant scoring. And what you see there, I didn't include this in the talk, but what you can see is that, we said DSA, is the biggest variable in terms of access to transplantation geography. But what you see is, if you look deeper at that, and we've done that just relatively recently, that in fact, within the DSA, what really is the biggest factor are varying center effects. And so, some DSAs have a lot of transplant centers in them and some do not. But the center's acceptance practices really vary a lot. And this is, it's a little harder to, from a patient standpoint, to assess that. But, in terms of access to transplantation, what center you list at does matter. How a patient would use that data, or could access that data to make decisions about which center to list at I'm not 100% sure how that will be, but going forward, one of the center metrics that they're going to be evaluated on is offer acceptance rates. And so, that data will be public. And so, I guess you could argue with more data, maybe the value of multiple listing will go down a little bit. I mean, listing in Maryland, for instance, it was always fairly common to list in, the Baltimore OPO and then go to DC and list at the DC OPO as well. And so I think that the value of that, I think, will be decreased, would be my guess.
Technically, though, if you were to do that and you were looking at that 250-mile radius, you're still, you're still sort of shifting the radius, right? by listing at 2 centers at once. Like you're catching a little bit more on the northern side if you're listed in Baltimore, and a little bit on the southern side if you're listed in DC.
Yeah,
Not by
sure.
a lot.
Nope,
But-
that's true. That's true. I mean, maybe somebody would want to list, you know, in Baltimore and then go list in Chicago or something. I mean, I suppose you could do that. And how that would impact your ability to your transplant rate, I'm not sure I have the you know, the ability to figure that out right at the moment, but theoretically you could do that.
Okay. All right, another question that came in. In New Jersey, there's a question from someone who's joining us from New Jersey. How many OPOs are in New Jersey to see if multiple listing is beneficial in the same state? And I guess it's asked.
You know, the maps are complex, to be honest. I think New Jersey has, I'm not sure if the Philadelphia-based OPO, it might cover a small portion of New Jersey. I'm not 100% sure about that, but I think essentially there's one OPO in New Jersey. And then there's, so I don't think that there are issues like that. But, you know, one of the big you know, there are differences in, you know, New Jersey is right across the Hudson River from New York City. And those are clearly historically have been different OPOs. And some of the controversies in allocation have arisen because of that hard boundary that goes right up the Delaware River. And so, you know, I think continuous distribution will address, you know, some of those issues.
Okay, a question from one of my partners. So as a referring nephrologist, how do I explain the listing process to my patients? Meaning, is there a simple way to explain to the patients that you know, why we would refer to a specific transplant center?
Well, you know, it's hard. I'm not sure I know how everybody decides, you know, where to refer patients to. I think, you know, that you know, transplant rate is one thing, but there are many other issues as well. You know, in terms of communications between transplant centers, you know, location, ease of access, you know, issues like that. I think that's a complicated decision, you know, which transplant center to go to. I'm not sure I have a simple answer for that, to be honest.
That's fair. Any other questions?
Again, I think, you know, there's been a lot of evolution in the transplant system, and so it's changed a lot. Again, just in the past few years, it's going to continue to change. You know, I think it's all changing for the better as a whole, and I think you know, some of the legal issues are starting to tone down, and so I think that's a good thing. There was a federal lawsuit around the kidney allocation system. That lawsuit has been withdrawn, and so I think we're kind of beyond that. And so I think, you know, at this point, I think continuous distribution will be the system that I would hope would be sort of for the long haul.
So I have one last question regarding that. Once this algorithm is constructed by, like you said, one of your software engineers, and the program is written and you guys decide to adopt it, how is the community going to be sort of alerted to that change? And is there a team within the organization that's going to mobilize and, you know, sort of spread the word? Because with some of the stuff that's going on, you know, in nephrology, even with, for example, the recommendation to get rid of a race-based modifier for, you know, the EGFR equation, we've seen that adopted really early at some academic centers, and then now some community centers are just starting to do it. And so you know, it's kind of one thing between recommendation and another, but when you're talking about actual implementation and getting the word out to all of us community folks.
Yeah, you know, let me think. The software engineers don't write the algorithms. I mean, that's, you know, they put in place the algorithms that are designed by the kidney committee in this case, and actually multiple committees and work groups. And so that is a very I think it is a very public process. You know, those meetings are accessible. The output of those meetings are public documents. A policy change like this will definitely go out for public comment. There will, you know, to the extent that we can, the OPTN UNOS sends out, you know, lots of communications to transplant centers urging, you know, comment on, you know, on the system and whatnot. Once it's adopted, it should not be a surprise to anybody. I mean, it should be out there, and should not be any surprise about that. I think it does take a while. People tend to put it to the back burner, not think about it, and once it starts, there can be some initial confusion. But there should be lots of educational resources that are put out to explain the system. So it should not be a surprise.
All right, one last question just came in, and then I think we're gonna sign off. But this is going to be a tough one for you to answer, I think. How do I explain to my patients when they are told by doctors that the new allocation system is worse for them in southern New Jersey, away from the big cities?
I think I obviously I don't know the answer to that, and I think again, when you talk the new allocation system, you're talking about the one we currently have, I guess, which started back in March. I think there is a lot of data still coming out about that, and in terms of, you know, trying to define winners and losers, you know, in that context, I think you have to be careful about that before you decide, you know, which centers are getting more organs, which centers are receiving fewer organs, which centers transplant rate has changed. Lots of things go into those, you know, in terms of, you know, decisions that are made not only by the allocation system, but by transplant centers themselves and by OPOs. And so I think I would be a little reluctant to sort of, you know, sign on to any statement that, you know, a certain portion of New Jersey has, you know, worse access based on this. If you look at the monitoring reports, it does get very granular in terms of individual transplant centers, how many organs they've seen, how it's changed relative to that. So I would sort of say, let's see what the data shows. The 1-year report will be out next week. And I think, you know, trying to make judgments based on, you know, people's initial impressions on how they feel over the first few months probably is not wise. I think you have to, you know, transplant rates go up and down, and there's a lot of fluctuation just randomly within the system. And so I'd say, let's see how the data plays out. So I don't know if that probably doesn't answer the question very well, but I think, you know, there is enough transparency in the system that people should be able to look at it and make judgments.
All right. Well, thank you so much for your time. I mean, I found it to be extremely informative, and hopefully everyone else enjoyed as well. Good to see you again.
Yes, it's not exactly I see some friendly faces there on the screen, so that's good to see. So thumbs up to you guys. It's, you know, it's not a clinical talk, and I know mostly these NKF renal rounds tend to be clinical, and so this is a very kind of policy oriented thing. So maybe it's a nice change of pace for somebody. But you know, if they have any questions, you know, I'm available. You know, just my email, I didn't put it, is, you know, david.klassen@unos.org. You know, so I read emails, you know, so if there are questions, I'm happy to try and answer them directly. So.
All right, very good. Well, thanks for your time, and hopefully we'll get
if I don't know the answer, you know, there's a lot of smart people I work with who are way smarter than me, and they know the answer if I don't. So if I don't know the answer, I can find it out for most things.
Very good. All right. Hopefully next time in person.
Okay, thanks. Good to see you.
All right. You too. Take
Thanks,
care.
Dave.